Hello, my name is Ibusalume Aigbe. I am a PGY1 internal medicine resident at Orange Park Medical Center, located in Orange Park, Florida. Today, we will be discussing hyperkinetic choreiform movements secondary to basal ganglia calcifications and underlying deep venous anomalies. Unilateral hyperkinetic choreiform movements represent a rare subset of movement disorders characterized by acute and sudden onset of progressive uncontrollable body movements. Our patient today is a 58-year-old Caucasian female with a past medical history of coronary artery disease, hypertension, and type 2 diabetes, who presented with uncontrollable left-sided body movements and headache. The symptoms began 1 month prior to presentation with a diffuse headache and uncontrollable movements of her left foot, and over time progressing to her entire left side. Exam was notable for uncontrollable movements of both left, upper, and lower extremities. Movements were random with no inciting or alleviating factors and not receding with distraction. Preliminary labs included thyroid stimulating hormone, anti-nuclear antibody, and rapid plasma reagent testing, which were all negative. MRI would be notable for right-sided unilateral calcifications within the basal ganglia, corresponding to likely deep venous anomalies and with nonspecific white matter changes. The patient was suspected to have hyperkinetic choreiform movements, likely secondary to calcification and underlying deep venous anomalies. The patient responding with severe mitigation of symptoms to initial dose of 0.25 milligrams of clonazepam twice a day, which was then increased to 0.5 milligrams of clonazepam twice a day on discharge. Chorea are a subset of movement disorders, typically classified as random, involuntary, and irregular movements with a writhing quality. Etiologies include hereditary causes such as Huntington's disease. Non-hereditary causes include Sydenham's chorea, as well as autoimmune, drug-induced, toxic, and metabolic etiologies. Vascular causes have been presented in the literature, and chorea has been seen as one of the most common movement disorders presenting after strokes, particularly when the subthalamic nucleus is involved. Unilateral chorea in particular has been associated with vascular causes such as arteriovenous malformations and subdural hematomas, in addition to strokes. Unilateral hyperkinetic movements associated with underlying pathology of the basal ganglia are primarily reported in conjunction with prior strokes. Acute onset without any of the underlying risk factors mentioned above has not been thoroughly established. Deep venous anomalies are a benign congenital malformation of veins in the brain. Often discovered incidentally on imaging, they drain the normal parenchyma of the brain. Although common, deep venous anomalies are typically benign and asymptomatic. However, with advancing age, they can progress, with ischemic and hemorrhagic stroke being rare complications. Cerebral calcifications in association with deep venous anomalies are infrequent in the literature. However, prior reports are lacking presentation of hyperkinetic movements. To our knowledge, we found only one other reported case of similar movements associated with cerebral calcifications and deep venous anomalies. In conclusion, unilateral choreiform movements in association with basal ganglia calcifications and deep venous anomalies represent a rare presentation in patients who present with movement disorders. After ruling out hereditary, medication-induced, toxic, metabolic, and other known etiologies, brain imaging should be used in conjunction with history to deduce causes. Thank you.